Juju Smith-Schuster has been almost absent in the New England Patriots offense thus far this season, and his movement on the field does not look explosive. Many have pointed to Juju's knees as being the source of his lackluster performance and sluggish gameplay. He experienced a knee injury during last season's AFC Championship game between the Kansas City Chiefs and the Cincinnati Bengals, causing him to leave the game in the third quarter. He underwent extensive rehabilitation with trainers to recover in time for the Super Bowl, where he contributed significantly with 7 receptions for 53 yards in a win against the Philadelphia Eagles. Following the Super Bowl, he allegedly had a, quote, cleanup procedure, and then apparently encountered swelling issues during a flight to Japan in March, which forced him to take some time off for recovery, leading to his absence from the Patriots' spring camps. Nevertheless, he remained dedicated and attended every day of training camp. In regards to some of the recent coverage about the knee, Smith-Schuster stated, "I don't believe my knee is a potential problem waiting to happen. If anything, it's growing stronger with each passing day." Well, that might be true, but something doesn't seem right, and the stats are not refuting my stance. In 3 games, Juju has 10 receptions on 16 targets for 66 yards and no TDs. At this rate, I think Juju's looking at like a 500 to 600 yard season. That's not what we wanted. Admittedly, I had Juju at like 750 this year due to the number of receiving targets on the roster and max affinity for tight ends and running backs. However, I'm still concerned about Juju. His legs look dead, and his pressure steps on slants look like he stepped in mud. His burst off the line looks bad. On one play, he was split out wide, and Henry was off the line in the slot. Henry almost beat Juju to 10 yards downfield. Juju's 10-yard split during his combine was 1.55, which is quick. Now, Henry has a 1.6, which is amazing for a tight end, but Juju should be quicker, and he is a couple yards ahead of Henry at the snap. To me, it looks like something's inhibiting his burst. My concern is that he is still dealing with recurring inflammation, pain, and possibly leg lock left over from his surgery. Inflammation causes what we call denervation and a drop of blood perfusion into the muscles around the knee. This results in reduced muscular output and even atrophy, which is muscle loss. More on this later. The question here is, what was the surgery actually for? Knowing what the specific surgery was for might give us some insight to what is going on and give us an explanation of why Juju looks like his legs are dead. Of course, we don't know for sure, but let's go over some options that I've seen in athletes over the years and how these injuries were managed for the athlete's return to play. Now, quick disclaimer, I do not know what Juju's diagnosis is or was, or any of his legitimate medical history. I am simply going over some possible scenarios that I've encountered over the years getting athletes back to practice and in the clinic, and more importantly, the conditions and consequences around those. I am no way attempting to diagnose or provide medical advice. Alright, so the first one I am looking at is a torn meniscus. This is due to Juju's ability to still play after the injury, but the injury required some surgery or quote-unquote a cleanup. Some background, the meniscus is a C-shaped piece of tough rubbery cartilage that acts as a shock absorber between the shin bone and the thigh bone, so in the knee. It can be torn if you suddenly twist your knee while bearing weight on it, so it is very common in football players or any sport where there's a lot of pivoting. If you've torn your meniscus, you're going to get pain and swelling within 24 hours, and it will reignite after repeated efforts or sessions, especially if the tear is small. But if the tear is worse, the athlete will experience swelling or stiffness, and twisting, rotating the knee is almost impossible. You also have problems, difficulty straightening the knee fully, and typically you'll have this feeling of the knee wanting to be locked up, or possibly feeling like the knee is going to give away. Clearly not conducive to being an NFL wide receiver. Now, conservative treatment and rehab for a torn meniscus can allow the injury to heal on its own. There is blood flow to the parts of the meniscus. In other cases, however, a torn meniscus requires surgery or procedure. This depends on a number of factors. The first is the type of tear. There exist various different types of meniscus tears, which each carrying their own set of consequences. Certain tears may display minimal symptoms, while others can lead to significant pain and discomfort during movement. The categories of meniscus tears that require surgical attention include a complete vertical longitudinal tears, there's also vertical radial tears, oblique tears, and there's just the advanced degenerative tears. Vertical longitudinal tears may not always be limiting, but when it progresses into a complete tear, spanning the width of meniscus, it transfers into what they call a bucket handle tear, which is symptomatic and restrictive. Many individuals opt for surgery in these cases. Most of the time, this is going to require surgery. Now, vertical radial tears are commonly found in the lateral meniscus. This tear typically aligns across the fibers, potentially causing discomfort during loading and may necessitate surgery for improved force distribution. Oblique tears are akin to hangnails. They have a tendency to catch on objects. These tears can lead to locking and catching symptoms, which can be alarming, especially for an athlete. If the knee unexpectedly locks up, it may result in a fall. Surgery might be advisable due to the functional implications of this tear. Now, there's degenerative tears result from wear and tear over time. This is synonymous with joint degeneration and osteoarthritis. Many individuals develop degenerative tears as they age, often without even realizing it. Physical therapy is usually the initial line of treatment, but in advanced cases, it often requires joint replacement. Now, there's certain types of meniscus surgeries. Now, there's meniscectomy. This procedure involves arthroscopically entering the knee and removing the torn portion of the meniscus. While it's minimally invasive and swift, the recovery period can be lengthy. Meniscectomies are susceptible to swelling, or what they call effusion, post-surgery due to partial removal of the meniscus, which affects shock absorption. Physical therapy plays an absolute critical role in monitoring swelling during the gradual return to activity. The supportive muscles around your knee will need to regain strength and functionality to assist in offloading knee structures. Now, there's also meniscus repair, which is a more intricate procedure than a meniscectomy. It is also minimally invasive, but instead of removing the damaged area, it involves stitching in the damaged cartilage back into place. Given the involvement of mending cartilage piece, there are stricter restrictions for the athlete's protection. Adherence to these protocols is absolutely essential. Now, a region of the meniscus with a really good blood flow typically takes 6 to 8 weeks just to heal. This is just the initial phase. During the healing period, a brace will be required, and depending on the tear's location, the athlete might need to be on crutches to partially or completely offload the knee. There are also restrictions on how far you can bend it in the initial weeks. This is supposed to safeguard the athlete from jeopardizing their own stitching and possibly causing a new injury. Surgery is tricky because MRIs don't always provide a comprehensive view of the injury, so the surgeon may encounter different scenarios in the operating room. This may lead to adjustments in surgical approach and subsequently in the post-operative protocol. Regardless of the surgery type, the initial days following the procedure involves dealing with swelling and managing discomfort, and this goes all the way through full recovery. Physical therapy can commence shortly after the surgery, often within the first week or two, depending on the type of tear and how well the surgery went. Adherence to restrictions is paramount in safeguarding the surgical outcome. Swelling and pain levels dictate your ability to gradually transition away from using a brace and crutches and getting back into something that's athletic. Deviating from the protocol will increase swelling and pain, which in turn hinders the progress. You gotta follow the protocol, otherwise you're getting a setback and might generate additional damage from inflammation. Yes, the inflammation from the knee injury and surgery is dangerous, especially if the blood stays in the knee joint. Full recovery following meniscus surgery can span from anywhere from 1.5 all the way out to 6 months, contingent on individual circumstances. Typically, a return to sport activities is closer to 6 months. Keep that in mind, 6 months. Juju had an issue back in March, so we are getting close to him being maybe back full capacity. If the injury involves other structures as well, the recovery time may be extended. In the interim, the athlete needs to focus on mastering fundamental movements and building strength to prepare to return to the sport without risking re-injury. One must understand that inflammation tends to shut down the muscles nearby. It is kind of like an internal safety switch for your body to prevent you from using the joint and creating more damage. Even a simple cleanup of the knee still hinges on the athlete's dedication to the rehabilitation process and limiting inflammation. Doing PT for the knee is a lot of discomfort. Yes, it stinks, especially in the initial sessions as the sports med and strength conditioning staff work to mobilize the knee. Preventing stiffness in the joint is crucial as it significantly prolongs the recovery process. You gotta move. Restoring full extension of the knee is the primary objective. Strengthening quadriceps is the most effective way to maintain this extension and sets the stage for bearing full weight when the athlete is ready. As the knee gains flexibility and strength over time, and as restrictions are gradually being lifted, the strength and conditioning staff will eventually incorporate additional exercises in the regimen tailored to the athlete's specific needs. These may encompass achieving a complete range of motion, normalizing a walking or running pattern, performing basic squats. Another big thing is bracing against outside forces, pivoting, and navigating uneven terrain is another big one. For receivers, special attention will be placed on jumping, running, and ultimately a return to running routes. The big thing is still monitoring swelling levels as the athlete progresses. Overexertion can lead to an uptick in swelling, indicating the knee is enduring excessive stresses. Now, increased swelling during everyday activities outside of PT is a concern because they indicate the athlete is prone to swelling or their surgery was not successful. Now, there's other things besides a meniscus tear. There's patellar tendonitis, chondromalacia, patellofemoral pain syndrome, bursitis, or even worse, bone contusions, dislocations, or a potential ligament or tendon tear. Most of these don't require surgery, but they still could be in play. Let's discuss some. Now, patellar tendonitis is often referred to as jumper's knee. It is a commonly encountered overuse injury in sports. This condition primarily affects athletes engaged in activities demanding significant eccentric loading of the quadriceps, such as basketball, volleyball, long-distance running, and skiing. Yes, football is also in there. This is typically due to impact from landing from jumping or repeated wear and tear from running, especially on turf. The origin of the patellar tendon is the most frequently affected region, which is just under the kneecap, and we can tell this because it's typically displaying thickening. This suggests pathogenesis of patellar tendonitis involving impingement between the deep fibers of the patellar tendon and what they call the inferior pole of the patella during flexion. So in the back of the patella tendon, just under the kneecap. This theory explains the characteristic site of a lesion that forms in that part of the tendon, primarily located at the very proximal minimal posterior aspect of the tendon. So, essentially, the kneecap is rubbing in the back of the patella tendon. Now, for us, we use two clinical signs. There was the passive extension flexion sign and the standing active quadriceps sign. We would use these assessments to track the athlete's progress after they've been diagnosed with tendonitis. Now, while ultrasound and MRIs are considered the preferred imaging modalities for evaluating tendon disorders, but the inflammatory regions seen on MRI scans are less reliable indicators of patellar tendonitis compared to increased tendon thickness. Now, for us, it was the actual physical examination where you would check the thickness and the stiffness of the tendon. If the physician determined that it has improved, we were given the green light to proceed to the next stage of the recovery. Now, typically rest and rehab does work, but if it does not, there is arthroscopic resection of the lower patellar pole. It is a possibility. Now, there's also what they call chondromalacia. In this case, it would be chondromalacia patellae. It's a term to use to describe the damage or softening of the cartilage of the underside of the kneecap. It is similar to patellofemoral pain syndrome, which we'll get to in a little bit, in which pain is felt under and around the kneecap. This condition is common amongst young athletes, but also can occur in older athletes who have arthritis of the knee. Chondromalacia patellae is caused by irritation of the underside of the kneecap, or due to an acute injury such as a fall or a long-term overuse injury we see in sports. The strongest link to chondromalacia is often the improper knee alignment, and there can be many reasons for this. You got just a congenital misalignment of the knee, flat feet, repeated stress of the knee joint during running or jumping, weak quads or hamstrings, okay, imbalance of abductor or adductor muscles on each side of the thigh. Basically, pulling your thigh in and out of alignment compared to your feet. Now, diagnosis of chondromalacia patellae is a combination of physical exam and usually imaging tests such as x-rays or MRIs. The x-ray can typically reveal bone damage and arthritis, while the MRI is good for spotting deterioration of the cartilage. Treatment is going to be a lot on rest, rehab, and reducing inflammation. But like the others, in some cases, you might actually have to have surgery. Now, what's interesting is this is a cleaning up procedure where the surgeon uses a specialized debriding tool to smooth the surface of the articular cartilage flaps and clean out any fragments that have been causing the joint to catch during movement. In both cases, physical therapy is required at the end because you need to strengthen the quadriceps and the surrounding muscles so the knee is in better protected position from injury. This usually involves a lot of low-impact exercises such as swimming or stationary bike movements. Also, isometric exercises, which involve flexing and releasing specific muscles and improve the functionality. The next is patellofemoral pain syndrome. Now, this is the one that's kind of at the front of the knee, around the kneecap. Like chondromalacia, patellofemoral pain syndrome is also termed runner's knee, but it's usually categorized by the pain being very superficial and more around the kneecap, whereas chondromalacia is more of a deep pain inside the joint. The knee pain often increases when running, walking, going up and down stairs, sitting for long periods of time, or squatting. Surgery is an option here if rest and rehab does not work. I went back into my notes, and my only athlete to get a surgery for this was older, and they got what they called a lateral release surgery. This involves the fibrous bands attached to the outside part of the kneecap are too tight, and they're pulling the kneecap out of position. Surgeons usually cut this tight structure, allowing the kneecap to move back into track. You're looking at 4 weeks at minimum to get back into some sort of sport-specific movements. Another one that's a little bit long-term is kind of this knee bursitis. It is inflammation of small fluid-filled sacs called bursa, situated near your knee. Bursa reduce friction in joints, and they cushion pressure points between your bones and tendons, muscles, and the skin near your joints. Any of the bursa in your knee can become inflamed, but knee bursitis most commonly occurs over the kneecap or on the inner side of your knee just below the joint. Now, it causes a lot of pain and it can limit your mobility. Treatment for knee bursitis is, again, a lot of combinations of just reducing pain and inflammation, rest, and rehab. Now, for football players, this doesn't usually come from the wear and tear of running, but comes from a sharp blow to the knee, which causes the symptoms to rapidly appear, and they become recurrent from it. But even for football players, bursitis can come from just general wear and tear. Like others, surgery is performed only when conservative treatment is ineffective, which involves surgical removal of the bursa. Again, rest and rehab that can take months is involved. Now, there is the possibility that there's a ligament or tendon tear that was in there, but I think that's less likely unless the medical staff is inept or it was incredibly minor that was basically undetectable. Now, I'm telling you this because they have artificial intelligence that read MRIs these days. So I highly doubt there was any serious damage that went by several sets of trained eyes and a computer's countless data sets to miss a big injury. So I doubt a big acute injury even occurred. Maybe there was a quick dislocation or contusion that caused some damage in there, and they were just dealing with some of the after effects. But I would find it hard to believe that there was any recent acute injury going on there. Another scenario to even consider is that the athlete has developed a chronic inflammatory condition that is generating serious inflammation, including some sort of form of arthritis. This includes psoriatic arthritis or rheumatoid arthritis, which can amplify the inflammatory response to just a basic injury. This is addressable with biological treatments. I am not saying that this is the situation, but we must discuss all scenarios. Now, going back to meniscus and some of these chronic inflammation conditions like patellotendinitis, chondromalacia, patellofemoral pain syndrome, and bursitis. These guys can be really hard to diagnose because it's inflammation in the knee, and the primary causes are basically the same. Sometimes just being around the athlete and working with them, you can get some observations that can help you figure things out. In patellar tendonitis athletes, we would see a quick onset of pain and the inflammation once the athlete started to perform high impact exercises. However, low impact or low intensity lower body movements were less likely to aggravate the tendonitis, sometimes even at all. This was regardless of the athlete's warm-up or the duration of the exercise. It was really based upon the intensity or type of movement. Now, chondromalacia was very tricky, but it always seemed to be a matter of time regardless of the intensity or the exercise. Eventually, in the early phases of recovery, pain and inflammation would show up in training sessions. The same with patellofemoral pain syndrome. Bursitis was almost always an issue that was present before the session even started. It was almost always there, but it was very temperamental in how bad it got. Now, navigating, recovering, and return to play from all these were very tricky because there's such varying degrees of severity and types of tears or degeneration, which typically determine the symptoms and the recovery protocol. I will say, it's rough at first because anything can trigger the inflammation and pain, but thankfully, that improves over time and as the athlete goes through their rehab. The biggest factor here is inflammation. Let's talk about how this is a major issue long past the acute phase of the injury and how it can really impact playing performance. Now, not a lot of people know about this, including athletes and coaches, that skeletal muscle function really takes a hit when there's inflammation present. The muscle undergoes a loss of contractile function when denervated, meaning the loss of nerve supply to the muscle, which leads to reduced blood flow perfusion or blood supply to the muscle. This reduction in blood flow results in a state of what they call hypoxia, or lack of oxygen to the tissue, triggering an excessive production of what they call reactive oxygen species, which causes oxidative stress injuries and a substantial increase in generation of inflammatory factors. These inflammatory factors further activate the inflammatory response pathway, leading to increased inflammation, so it snowballs. This overreactive inflammation then initiates a cascade effect, prompting muscle atrophy or muscle loss, which is the enzymatic breakdown of proteins, or muscle. It also decreases protein synthesis, so the ability to rebuild muscle, and hindered muscle regeneration, ultimately resulting in skeletal muscle atrophy and fibrosis. So, loss of muscle and stiffening of muscle. So, inflammation leads to oxidative stress, which contributes to skeletal muscle atrophy. Suppressing the inflammation or the associated signaling pathway has been shown to effectively mitigate the denervation-induced inflammatory responses in skeletal muscles. It also inhibits the activation of pathways that prevent skeletal muscle atrophy. The take home here is that it is crucial to get the inflammation under control, because you'll stop the process of denervation-induced muscle atrophy. It's a huge concern after an injury and during recurring inflammation. So, not only do you need to worry about the injury in terms of the structure, like the actual damage done, but you have to worry about the inflammation causing muscle deactivation and muscle loss. Yes, the longer you have inflammation in an area, you're going to have muscle loss, which obviously only makes things worse for the injury and prolongs the recovery process. Now, I'm going to tell you a little quick side story. I had an athlete go on a cross-country trip with their family over the summer, and they broke their ankle hiking. They didn't get surgery on the road, so he had a hard cast on, and they stayed on the road for another 2 weeks. He never got it drained, just had a hard cast and crutches in the middle of nowhere, USA. Dude came back, calf was basically jelly in less than 3 weeks. That leg underperformed the healthy leg for the next 2 years in every asymmetry test, despite him having intense rehab, therapy, and return play protocols. He did his best once he got back, but basically it derailed his college career because he never got the inflammation under control in the first few weeks, and the nerves just took forever to come back. Another side story was from a college cross-country runner. She came in as a graduate transfer with chronic ankle and shin issues from grotesque running form that was never addressed at her previous school. Her times had steadily declined since her sophomore year. Well, it turned out that she had had this overuse injury since then, and she had almost always had inflammation present. After assessment, her ankles were wrecked. They were fibrotic, they had limited range of motion, her lower extremity was just markedly weak. She got the full buffet of treatments and rehab to get her back going, but the prolonged muscular inhibition had caused its damage. This is why you have to get the inflammation down immediately and get the athlete in for stim and moderate work to keep their muscles alive, essentially. Otherwise, the inflammation will start the cascade of physiological events that would really have a lasting impact on the athlete's performance and their career and even possibly their lifestyle. That being said, you gotta take your rehab seriously. I know it often sucks, but it is how you can get back quicker and more complete. If you don't, you probably won't be as quick or as fast or as powerful as you used to be. Time's ticking, and you have to take your rehab seriously. As we're talking about rehab, what is the common rehab and what are some prevention exercises? Some of the best are what they call open chain exercises. These are ones you typically do when you go to PT. You got the seated leg extensions, you got knee extension exercises, hamstring curls, plantar dorsiflexion, which are like calf pumps, so toe going forward and back. They're basic exercise and often are extremely boring, but they're not weight bearing. So they're easy to execute and they're adjusted for the athlete. Now, once the athlete gets going, there's another type of training to eventually add on, which is called eccentric training, which emphasizes the lowering portion of an exercise or the relaxation portion of the rep. For squats, it's the descent portion, where we got to go slow reps with moderate weight and eventually increase the load over time. This helps develop the thigh and hip muscles to handle the impact of running and jumping. You need those muscles to be active and strong to take the pressures of the knee. There's also isometric exercises, which also work great. The athlete holds their position and exerts into an immovable object. A great example would be like a wall sit. Of course, you could add in balance and unilateral training as the athlete progresses, and then start integrating their sports performance training into the mix. The point here is, you got a lot of options, but most of them are very boring. You don't have that face value relation to the sport. But you have to do these types of exercise because they're less likely to cause immense amount of stress and inflammation on the injury. Plus, the athlete can focus on the contraction, their form, and the function of the muscle, rather than just speed and weight. It's tough to convince an athlete who can put up 600 in the squat that he needs to go over to the therapy table and put up a rolled up towel under his thigh and just flex his quad for 5 minutes. But these are the things that need to happen. Anyway, let's bring it back to Juju. Again, I don't know what Juju's injury was. I don't know what the surgery was. I don't know how well the surgery went. I don't know about his rehab. I don't know what the Patriots knew about his knee and what they know now. But something does seem off. I am talking more than just his route running mishaps. The 2 back shoulder fades to Juju against the Jets were like frustrating to look at. Honestly, I think Mac threw 2 rancid passes there, but I'm just not seeing crisp routes or ability to adjust. I watched Juju see the ball and then realize Mac's throws were off target, but he makes like literally no effort to really make an adjustment to try to catch the ball. Is he just giving up, or does he know he can't physically get there anymore? It's concerning and frustrating, honestly. Juju's supposed to be a possession receiver, which relies on rarely dropping a pass. He's supposed to be physically strong. He's supposed to be able to get off jams off the line of scrimmage, running disciplined routes to allow the quarterback to throw the pass before the route is finished. The great ones make every route look the same, whether it's long or short. Plus, they have a knack for really setting up a defender, saving the key moves for a pivotal juncture. A burst of speed, and they just rack up yak. Right now, I got maybe one of those abilities checked off. The rest, not really for Juju. Now, some of you might think it's a major issue if Juju's knee is not 100% and it's hindering his performance. But the way things look, I would actually rather kind of prefer him having an issue with his knee over him not being able to pick up the offense or possibly suffering from I just got paid syndrome and I am now phoning it in to collect and cruise on this contract. So I hope it's actually a matter of the knee and return to form rather than just a question of effort or ability. There's also the risk that he did rehab and his ability to reactivate his nerves have passed on. Keep in mind, this is not his first knee injury. Maybe the body is not responding to the rehab and we cannot reanimate those legs to have spring or burst anymore. Everything might be stripped at this point. Now, is it all on Juju? Well, even if Juju is 100% and nothing is really wrong with his knees, I still think the Patriots are not really able to as more of a possession receiver because he's certainly not a sudden slot receiver, or he's definitely not a speed receiver. Why is that important? Well, let's take a second to discuss a concept that is often egregiously misunderstood and often fraudulently used by some in the media. A possession receiver is one who makes tough catches typically in the middle of the field. They aren't burners. These are not guys who outrun the defense and make long, deep plays. They're the tough guys who get the first down and can expect to be hit as soon as they catch the ball. A possession receiver tends to make those clutch plays. They move the chains, they get first downs, and they chip away at the field. The big thing to consider here is, what is it that possession receivers need to do in order to be their best? It is in the name. Have possession of the ball. Indeed, that is not necessarily why they are called possession receivers, but it does help you categorize them because the other types of receivers are better categorized by what they do before they get the ball. They do most of their damage before they get the ball. They do the damage on their route running and ability to stress the defense. Possession receivers can have an impact on defenses in terms of responsibilities and counting for them, but they're not forcibly stretching the defense out and down or horizontally or vertically in the air. Gosh, I cannot stand hearing people trying to talk about individual route running performance for a possession receiver. You don't diagnose a possession receiver based on what they do before they get the ball. That is not where they do their work. Juju has never been a guy who gets separation from route running, so stop running that filter on him. Think of a defense as a giant dome, right? Alright, so let's do an exercise here. Think about a defense as a giant dome or like a bubble, right? When that dome or bubble is small, all the contents are closer together, so it's stronger, and it's better at withstanding the pressures. But when the bubble's spread out in 3 different directions from within, it thins out and it's weaker. The edges are being pushed. The speed receiver's pushing down the field, right? The sudden slot receiver is pushing to the sidelines. The high point receiver is stretching vertically. So we got 3 different directions going there, right? This should leave the defense stressed and provide space for the offense to operate. Now the possession receiver is supposed to benefit from the other receivers stretching out the edges of the dome by taking advantage of the softer underbelly with good route combinations designed to get them open to catch the ball and move the sticks, and possibly breaking the bubble from within, which is where geodesic domes are their weakest. The other receivers are not necessarily decoys all the time, but unless they have a huge mismatch or blown coverage, the throws to those receivers are not high probability, as the one the possession receivers should be running. Now, we had this long alliteration-like statement centered around P that described play calling. It was something like progress our possession with probability play calling. We used to use that statement 2 different ways. One, if you're going to maintain possession, make sure you're calling plays that are high percentage. The other thing we would use it for was describing how we would do it. Our possession guy was the goal of the play calling, because I wanted to get the ball to the guy who's going to catch it in stride with space in the middle of the field for most of the drive, rather than throw it to the guy on the sideline who's just going to catch it and drop or run out of bounds. If we really wanted to mash up the defense, we're going to have to beat it up, not skin it. Juju is a possession guy, but at one point he was pretty good at being sudden, not bad jump balls, and wasn't horrendously slow. Now that we're arguably seeing a loss of some twitch, we have to revert to what Juju is, a possession guy. But he is doing this from the slot receiver position. So, his route tree is extensive, but a bigger possession slot receiver is dangerous moving across the middle on drags, crosses, over, slants, or maybe like a quick out in the other direction. Again, mashing up the middle and not skinning it. Of course, you can also pull off some sit, pivot, whips, hitches, spots, or even a smoke route. But getting Juju moving across the middle is where he can get that ball in stride and take his 220 pounds against corners and safeties who are struggling to find a good angle of pursuit on him, because they were torn by the speed, sudden, and contested catch guys tearing them away from the middle. Juju can then find his alley and use his yak skills to pick up the big chunks. Keep in mind, this happens because the other receivers and route combinations allowed it to happen. Then why was he good? If all those other things are needed for him to be good, then why was he good? Well, Juju is really tough to arm tackle, which is typically what you're going to get from corners and some safeties. Juju is really smart when he gets the ball. He finds the defensive backs and moves to where they're going to try to wrap him up around the shoulders rather than hit him square up. and they'll just slip right off him. What you're looking at is basically a running back receiver. His skills are not jukes and breaks, and he doesn't shake defensive backs. He doesn't do Odell Beckham catches. He isn't going to snap off D-backs like DeMario. He gets the ball thanks to proper play calling and a stress defense. When he does, he has the vision and instincts to get that big yak. He has decent hands, and he's great at boxing out D-backs to position himself for a tough catch. He's also a solid run blocker. So I think some of this goes back to, do the Patriots have the guys to stretch the defense to allow Juju to work? Another question is, does Mac have enough time to get the route combinations out there to help Juju get open? Maybe his performance is not entirely his fault. Maybe there's some misuse going on. As a result, Pats fans need to accept that there's a possibility of what we're seeing right now is what Juju is at this point in the season. Hopefully we're not looking at Juju as peak for the season, or even worse, hopefully not the peak for his time here in New England. Personally, I don't think Juju is cooked or whatever you want to say. I think he does need some time to get up to a better playing speed. I think the play calling needs to benefit him. And it really kind of rests back on the offensive line, who needs to unlock those plays with better protection to permit the route combinations that will help Juju get the ball. In terms of the potential issue with the knee, honestly, if Juju was really having issues back in March, he might be finally getting back into normal function, especially considering the cumulative impact of his previous injuries. Regardless of the underlying injury right now, he needs time to get all the way back. Hopefully we will see full strength by week 6, and the offense has all their weapons back. Well, I hope this helps you out a bit. First, understand some of the scenarios, and then also the importance of getting rid of inflammation in an injury. It's also going over what a possession wide receiver is, and how do you actually analyze their performance. Hopefully at least you got some information out of this. Now, let's see how Juju is this week against Dallas. What do you guys think about Juju's performance thus far in the season? Do you think there is a knee issue? Are the Patriots even using him correctly? Let me know in the comment section below. If you like my content, please like and subscribe. And as always,